So, hello, good evening, everybody. Today, hopefully, we'll give you some insights on GERD from a functional medicine approach. Our educational objectives are displayed here, and let's do it. So, physiologic reflux. Gastroesophageal reflux disease, or GERD, is divided into two. You have physiologic reflux, which most people, everybody is going to have some physiologic reflux, and then pathologic reflux. And pathologic reflux is if you have reflux of the gastric content into the esophagus, causing symptoms or causing injury to the tissue. So the typical reflux symptoms, if you look at the most common symptoms of reflux, one is going to be heartburn, also regurgitation, and dysphagia or difficulty swallowing. And there's really little agreement on what classic reflux is. So, but those are some of the vague terms that the patients are going to describe to you. We do have the Montreal classification here. And basically, the Montreal classification is saying that if you have symptoms and greater than 2 times a week and they're persistent, then you can make that diagnosis of reflux. So you see, one of the challenges we have is there's no test to do. It's more of a historical type of a diagnosis. So what is the prevalence of reflux? 18 to around 27.8% of the population suffer from reflux. And what is the complications of untreated reflux? So we see this often. We see people that don't want to take medication and they're just kind of fighting through it, or they're toughing it out, and we don't want them to do that either, because if they do, it could lead to esophageal strictures. It could lead to Barrett's esophagus, which is a pre-malignant condition. They can get hoarseness, they can get laryngitis, asthma, cough, insomnia, sleep apnea, and also dental erosions. And what I found clinically is that sleep apnea is often caused by GERD, and if you address their GERD, a lot of times you no longer need to use their CPAP or their sleep apnea devices. So what about the use of proton pump inhibitors? Well, what's happened is that proton pump inhibitors started out as a prescription, and they were supposed to be benign. There's no real issues with them. And when the first proton pump inhibitor lost its patent, they realized that they needed to do something to help with revenue. So what did they end up doing? Is they ended up convincing the FDA to allow them to put proton pump inhibitors over the counter. And now you have access to these proton pump inhibitors over the counter, and patients are taking them, and lots of patients are on them, and they're getting addicted, physiologically addicted to these proton pump inhibitors. But so what is the indication for proton pump inhibitors? Well, GERD is an indication, and as you see, the GERD is really a vague diagnosis. Gastric and duodenal ulcers, erosive esophagitis, H. pylori, stress ulcer prophylaxis, pathologic hypersecretions, and Barrett's. Now, Barrett's is one of those really challenging cases where I think you're kind of stuck. You need to have them on the proton pump inhibitors. But most other causes, using a functional integrative medicine approach, we can get them off the proton pump inhibitors, or at least get them down to a minimal use. Now, because it's over the counter, one of the concerning things is that if you end up going on it, they did a study where they took normal subjects that didn't have reflux and they put them on proton pump inhibitors, and around 40% of them couldn't get off the proton pump inhibitor. They ended up getting like this reflux afterwards, and they had to go back on it. So the scary thing is now patients just have some indigestion. They go over the counter, they go on proton pump inhibitors, and then they're stuck on them. Now, proton pump inhibitors are not really part of diagnostic criteria, but a lot of times in practice, what providers will do is they'll use proton pump inhibitors in order to diagnose patients. So oh, you have stomach issues or indigestion, go on this proton pump inhibitor. Oh, okay, the symptoms went away. All right, you're diagnosed with GERD. And they're responsible, the cost, the economic burden is around $11 billion per year. So if proton pump inhibitors were completely safe, then that would be great. That would be, then all right, they end up being on a pill long term, but no harm done. Well, the more we find out about proton pump inhibitors, the more we realize harm is being done. So what happens when people are on long-term proton pump inhibitor? Well, you need acid for a reason. There's a reason that the stomach makes acid. So if you're not making acid, then what can happen? Well, one of the things that acid does is it kills different bacteria that may be trying to make its way in the tract. So if you don't have that acid killing, or the acid that's killing the bacteria, then what ends up happening is that you can get C. diff infections. There's an increased risk of pneumonias. There's an increased risk of SIBO, or small intestinal bacterial overgrowth, which we're now finding out more and more about. The interesting thing is I started learning functional medicine around 10 years ago, and back then I learned about SIBO. And whenever I would talk about SIBO, gastroenterologists in the area would kind of dismiss it, probably because they didn't know what it was, or make fun of it. But now gastroenterologists are catching on board that a lot of people with irritable bowel syndrome have SIBO, which basically what SIBO is the small intestine that's supposed to have little bacteria ends up with a large amount of bacteria, leading to things like restless leg syndrome, fatty liver, poor absorption, and much more, and worsen GERD, because then as they start eating foods, those foods, certain sugars will cause a gas, and that gas will push up on push on the diaphragm and push on the stomach, and causing more refluxing. So it also increases the risk of bone fractures, because you need acid in order to absorb certain minerals like magnesium and calcium. You can end up with, one of the risks is what we already mentioned, the rebound acid hypersecretion. So what ends up happening is that your body knows that you need acid, so you go on an acid blocker, and the body realizes it needs more, so it starts increasing gastrin. And when gastrin goes up, the body tries to make more acid, but it can't make more acid because you're on a proton pump inhibitor. And then what ends up happening is the levels go higher and higher and higher. So then they stop taking the proton pump inhibitor, and then they end up with more pain and more acid than when they first started. So like we mentioned, you end up with it causes nutritional deficiencies like B12, magnesium, calcium, iron, and it can interfere with metabolism of certain medication that go through the same cytochrome P450 enzyme. Another risk of proton pump inhibitors is the proton pump inhibitors increase a substance in your blood called ADMA. Now, what is ADMA? ADMA actually competes with arginine with the enzyme endothelial nitric oxide synthase. So what ends up happening is ADMA will elevate, and it will block the body from making nitric oxide, and that ends up causing endothelial dysfunction, atherosclerosis, hypertension, and whatnot. So it leads to cardiovascular disease. So someone can go on a proton pump inhibitor because of a binge, end up getting addicted to that proton pump inhibitor, and then 5, 6, 7 years later, they can have a heart attack because they were on that proton pump inhibitor. There's new research also suggesting that GERD or that proton pump inhibitors also increase your risk of Alzheimer's disease. And there's a couple of theories on why. Well, part of it could be nutritional absorption, but one of the theories is that proton pump inhibitors actually cross the blood-brain barrier, and by doing that, they decrease they change the acidity in the brain, which leads to more plaque development and Alzheimer's and whatnot. So that's another thing to be aware of. So bottom line is if patients don't have to be on a proton pump inhibitor, we don't want to put them on one. Now, if you look at our proteins, where do we get our neurotransmitters from? Well, L-glutamine ends up becoming GABA, and your L-phenylalanine becomes L-tyrosine, and tyrosine becomes dopamine, and norepinephrine. So if you end up not having enough of L-glutamine, then you can end up not only not being able to repair the GI system well, but also you'll have decreased amounts of GABA, so that can cause anxiety. And then if you don't have enough of the L-tyrosine, then you don't get enough of dopamine, which can cause depression, and then you won't get enough norepinephrine, which can cause decrease in focus. And then your tryptophan you need in order to make 5-HTP and serotonin, and you also need serotonin to make melatonin, so you can end up with problems with depression, and you can end up with problems with insomnia. And as you'll see in a little bit, melatonin is needed for good gut health, so you can end up with worsening reflux. So why am I mentioning all this? Well, you need acid to break down proteins. And if you don't have enough acid and you can't break down proteins into these different amino acids, so if you don't have enough in your diet or you don't have enough acid, then what ends up happening, you can get all kinds of mood disorders and secondary disorders from being on those proton pump inhibitors. And remember, some people, they don't not have, their problem isn't they don't have enough acid. Their problem their problem isn't they have too much acid. Some people actually just don't make enough acid. So what is the functional medicine approach? How do we deal with gastroesophageal reflux disease from a functional medicine point of view? Well, first, we know that there's 7 underlying imbalances that cause all disease. They're centered around your psychological, spiritual, emotional state. And we know that one imbalance may lead to another imbalance, which eventually may lead to disease. So with functional medicine, we're no longer thinking this person just has a omeprazole deficiency. What we're trying to do is find out the root cause, what caused the reflux and the reflux symptoms in the first place, and then we're trying to rebalance the system. So this is the functional medicine matrix. I know many of you have seen this. And in order to understand the different imbalances that can lead to disease, I like asking a series of questions. So the first question is, what do you need to live? You need oxygen, you need water, you need food, so you need the micronutrients and macronutrients. And how does your body get them in the system? Well, through a process called assimilation. And most assimilation takes place in the gut. If you have reflux, there's a sign that there's a problem with assimilation in the gut. And if you go on reflux medication, you're causing an assimilation problem. And once they're in your system, then what do you need? What do you have to do? You have to transport it. And that's why we have the transport system. And if the transport system is off, that can lead to disease. Part of the transport system is the lipoproteins. So if fat does not mix well in water, and our blood is water soluble, so fat is not going to mix well in blood. So what does our body do? It makes LDL, it makes HDL, it makes triglycerides, and those are proteins that can carry the cholesterol to the different parts of the body. Your brain needs cholesterol to live. The rest of your body needs cholesterol to live. And what happens if you have a transport problem, that can lead to cardiovascular disease and whatnot. I'm on the faculty for the Institute for Functional Medicine's cardiometabolic module, and transport is the big thing that we're talking about when it comes to cardiovascular disease. So in order for it to be properly transported, we need good structure holding it up. So if you have a structural imbalance, that can lead to disease. And as structure is holding it up, well, how does the body defend itself against organisms that try to breach the system? Well, through the immune system, through defense and repair. So the body is defending itself, but also the body is always breaking down and rebuilding, breaking down and rebuilding. So you have in your bones, you have osteoblasts and osteoclasts, breaking down and rebuilding. You have in your brain, you have synaptoblasts and synaptoclasts. And if you break down more than you rebuild, that leads to structural integrity problems, and that leads to disease as well. So Well, one of the ways that the immune system does work is through communication, and communication is also your hormones. So you have you have your thyroid and your sex hormones and all the different hormones and cytokines. And if you have an issue with that communication issue, that can lead to disease. And what does the body need to run? It needs energy. So how does it make energy? Well, it takes those macronutrients plus micronutrients and oxygen, and it makes ATP. And if you have a problem with the production of energy, that's the mitochondrial dysfunctions that can lead to fibromyalgia, that can lead to Alzheimer's disease and Parkinson's and chronic fatigue and all of those things. So if you have a problem with energy, that can lead to disease as well. And as all that's happening, your body is amassing toxicants, and how does our body deal with it? Through biotransformation and elimination. And if you have a problem with biotransformation and elimination, that can lead to disease as well. And all of these 7 imbalances can lead to reflux. So what we have to do is find out what the underlying imbalance is by doing a good history and looking at labs and looking at clues, figuring out the imbalance and supporting that structure. And what's in the center of the matrix? Your mental, emotional, spiritual state. And what can happen? You can have somebody whose spiritual state is off, and that throws off, that can cause reflux, which could cause bad bacteria to start growing, or could cause them to go on a PPI, which could cause bad bacteria to start growing. Or you can get reflux, and you can get a lower immune system, which is a communication problem. And that lowered immune system allows small intestinal bacterial overgrowth, which can lead to restless leg syndrome. So I'm just trying to show you how everything is interconnected. And the mental, emotional, spiritual state is very important as well. Well, what about genes? Where do genes play a role? Well, most of our genes are turned off. And there's a small percentage, maybe 3%, that are turned on at any given time. So what do I mean by this? Well, if you look at every cell of your body, it has genetic material for your whole body. So if I took the tip of my finger and I looked at the genetic material in the tip of my finger, I have the genes for the color of my eyes. But if you look at those genes, you don't want the genes in the tip of your finger turned on for the color of your eyes. So the tip of the finger will have tip of the finger genes turned on. And immune system genes will turn on when they need to and then turn off when they need to. So most of them are turned off, and about 3% are turned on at any given time. And we can actually influence the way that our genes are expressed. So what is it that can change our gene expression? The environment. And that's why with the functional medicine approach, we are looking at the environment. So what is our environment? Well, sleep and relaxation. If you're not sleeping properly, then what can happen? Then you can't make your neurotransmitters. You can't make serotonin. If you don't make enough serotonin, just from a gut, you guys know serotonin can lead to depression and anxiety and all this stuff. But just from a gut point of view, you don't make serotonin, you can end up with constipation. You don't make serotonin, you can't make melatonin. If you don't make melatonin, it can lead to reflux. Then we also need exercise and movement. That's part of the way that our genes are expressed. There's 7 underlying imbalances that cause all disease, surrounded by your mental, emotional, spiritual state, and exercise helps all 8 of those things. So if we're exercising properly, one of the ways that it does that is that by exercising, you are causing your tryptophan levels to elevate, increasing the branch chain amino acids going into the muscles. Tryptophan elevates and then can go into the brain and then can help us make neurotransmitters and whatnot. Then nutrition. What are you eating? A lot of times people get reflux because they were eating things that they weren't supposed to. And instead of figuring it out and instead of listening to their body, it's easier to just take a pill. And then you take the pill and then you get addicted to the medication. So what are they eating? And we'll go over that in a little bit in the approach. And then stress. So what are they doing for stress management? Is stress, there's research that suggests that stressful situations aren't a bad thing unless you would think of it as a bad thing. It's the way that you internalize it. So if you actually take this stressful situation as a good thing, you could actually have health benefit. And then are people taking time to relax and to meditate or to reflect and to just kind of wind down? Or are we just running around like crazy people? And the last thing is the relationships. What's our relationship with ourself? What's our relationship with our creator? Are they in toxic relationships? What's the relationship with their spouse? What's the relationship with their kids? So if the relationships are out, that's going to throw off your mental, emotional, spiritual state, which will throw off your communication state, which can then lead to any of those other imbalances. So as a functional medicine provider, no matter what they come to you with, you're going to go over their sleep and relaxation, you're going to go over their diet and movement, you're going to go, exercise and movement, their nutrition, their stress, their relationships, and you're going to have prescriptions in these things where you find deficiencies. Doesn't matter what the diagnosis is they come to you with. And then we come up with a fine-tuned approach. So all components of the environment will help with reflux. But we want to go a little bit deeper. We don't want to say, okay, just diet, exercise, and make sure you sleep. No, we want to go even further, and we want to fine tune it. So, what are some considerations? So first of all, a lot of our patients on GERD are stuck on PPIs. So if they're on the PPI, the first question, you want to take them off of it, the first thing you got to ask is, do they have an indication for long-term PPIs? And one of the biggest indications you'll find is something called Barrett's esophagus, which is a precancerous condition. So what damage may have been done because of the PPI is the next question you want to ask. What caused the need for the PPI in the first place? And then gastrin levels might be high. We may need to wean off that PPI slowly. So these are all things that you're going to want to consider when they're on a PPI. Now, get back to GERD. Here's an interesting fact about melatonin. Newer research that we have is showing us that melatonin, the neurotransmitter that is thought to help with sleep, is not only about sleep. It turns out that 400 times more melatonin is made in the gut than in the brain, that sits in the pineal gland. And it's made by the enterochromaffin cells of the gut. And what does it do? Well, it decreases the rate of transient lower esophageal sphincter relaxation. So what it basically does is it's going to make that lower esophageal sphincter not loosen up as much. Remember, if you have a loosened sphincter, then what happens is it's a physiological sphincter, which means there's no door. That means that you're going to reflux content up into the esophagus. It also is going to inhibit acid secretion, but not to the extent of a PPI. It's going to, but it will mildly decrease acid in the stomach, which can help. And it also is going to stimulate sodium bicarb in the duodenum, and this also is going to help the GERD process. So if you look at melatonin, it actually has 3 mechanisms of helping with reflux. And this has become, I used to use a lot of things in helping people with reflux, but this has been one of my biggest go-tos just because it works so well. And remember, sleep, one of the environmental things that we need is sleep. If you're not sleeping enough, sleep is when we're making all our hormones. That's when we're doing most of our detoxifications. So if you don't get patients sleeping properly, then that can actually lead to a decrease in melatonin production, which can cause worsening GERD, which then can cause trouble sleeping. So it can become this vicious cycle. So what's the prescription? I will put them on 2 to 5 milligrams of melatonin every night. You do it at nighttime because melatonin is also needed for sleep, and you have to tell patients, look, I'm giving you melatonin, and you're going to look at melatonin and say, oh, my sleep's okay, but I'm not giving it to that. Just remember, melatonin I'm giving you for the reflux. I'll put them on an activated B complex because B vitamins are needed in order to naturally make your serotonin and your melatonin. And you do the B complex in the morning because you don't want them all stimulated at nighttime. And then work on the 5R programs. So so I just want to take a second because I talked about using supplements, and I think many of us here are using supplements, and many of us actually have the supplements in our offices. But what are we looking for in a supplement? Well, we're looking for third-party testing. We're looking for a hypoallergenic formula. We're looking for temperature and humidity control, and we're looking for stability testing. So when you're recommending supplements, what you have to make sure of is that they have these things. Last year, there was that study where they went and looked at certain major retail stores and looked at some of their herbs and found out that they really didn't have what they said they had in it. And at the end, what ended up happening after this big mess is they had to pay a fine, like a three-figure fine, so it was like in the thousands of dollars. But to these big retail stores, a couple $1,000s doesn't really mean much, and they had to sign a paper saying they would do better. The fact is, a lot of times you get supplements, you can get melatonin over the counter, and it doesn't really have melatonin in it even. It could have sand or rice or whatnot. And this has been one of the biggest reasons that the current conventional community has been very resistant to recommending supplements. Many times, like Up to Date is a great resource. It's a resource that I use all the time as a functional medicine doctor and as an internist and a pediatrician, but it'll mention a study on a supplement. It'll say, however, because we can't verify the quality of the supplement, we recommend you don't take it. So what do we want to do? We want to make sure that we are verifying that. We're making sure things are third-party tested. And then if they have a really good product, but it doesn't have temperature and humidity control and stability testing, it could be inactive by the time you get it. But anyway, that's enough about supplements, but they are tools in our toolbox. Now, let's get back to the melatonin. So let's say a patient can't tolerate melatonin. That happens pretty often. And the reason, well, one of the big reasons is they say they get like these vivid dreams. Well, if they can't tolerate melatonin, well, if you look at the pathway, just go a step further, and what do you need? Well, serotonin. Well, how do you make serotonin? Well, your body takes 5-HTP and turns it into serotonin. So what you can do is you can try giving them extended release 5-HTP and working on their diet and seeing how it works. And then go up the pathway. We see you need the vitamin B6 and the zinc, and you're going to have the activated B complex. You need folic acid. You need all of those things. But as the patient's getting better, you're going to move yourself up. So, okay, you give them melatonin, and then if their reflux is gone and you're working on lifestyle things, we'll go up. Okay, well, you can, serotonin you really don't want to give as in supplement form, but you can give 5-HTP that can become serotonin and become melatonin, and then you can go up a step further and say, okay, well, we want to increase tryptophan, and then if they make sure that they have enough stomach acid in the first place, and then give them protein, because protein is what's going to become tryptophan, which is going to become 5-HTP, and that becomes serotonin and melatonin. So work up that line. So the 5R program. So what are the 5R? What is the 5R program? It's remove, replace, reinoculate, repair, and rebalance. So what are we going to remove? We're going to remove bothersome foods. Very commonly, gluten and dairy are bothersome foods. High carbohydrate foods are they commonly are going to trigger reflux. You can try different diets, like, well, if they're very motivated, we can do elimination diets, we can do paleo diets. If somebody has SIBO, which they get bloated after eating, maybe they have restless leg syndrome, they may have fatty liver, they may have chronic diarrhea or constipation or alternation of both, irritable bowel syndrome, then if you're thinking they have SIBO, well, part of the treatment of SIBO is putting them on a low FODMAP diet. So if you don't know what a low FODMAP diet is, look it up. And I actually recommend everybody here figure out what is an elimination diet, what is a paleo diet, what is a low FODMAP diet, because all of these things are going to be tools in our toolbox and prescriptions that we'll be giving patients. You want to remove the bothersome organisms. So if they have small intestinal bacterial overgrowth, well, you may want to kill some of that. If they have a pathogenic fungi or parasite or bacteria, you may want to give either herbs or medication to help eliminate it. And we do advanced stool testing a lot of times in order to see what organisms are there. And then you want to remove bothersome foods. So there's IgE, and there's IgG4, and there's IgG testing. IgE can cause reflux because of a histamine-mediated reaction. And then IgG4 is more food intolerances. And these are all things that you consider testing. I think the gold standard, though, is doing an elimination diet. So other foods to try to consider avoiding, at least temporarily, till you can get the reflux under control. Well, chocolate, peppermint, spicy foods, caffeinated beverages, all of these things can worsen reflux. And acidic beverages like colas, orange juice, high fat and high simple carbohydrate foods. And really have them consider decreasing and doing the small frequent meals instead of doing large meals, which a lot of people are accustomed to. If they want, a trick that they can do is when they do have reflux, drink water and continue to drink water until the reflux goes away. So it may take them, they may need to do a 12-hour fast and then start a more bland diet in the beginning, and then small frequent meals, and then slowly increase their intake and don't just kind of get into that vicious cycle of just taking Tums or taking some sort of a pill for it. Then replace. What can we replace? They may be missing digestive enzymes. They may be missing acid, and that might be why they're having the symptoms in the first place. So you can give betaine hydrochloride. They may be missing fiber, which is a powerful prebiotic. They may be missing phytonutrients, vitamins, minerals, and amino acids. So you want to replace what's missing. So let's talk about vitamins and nutrients. Why would they have these deficiencies? What would make them have vitamin deficiencies? Well, we mentioned a couple of reasons. We mentioned that first of all, if they have a gut problem and they're having these reflux symptoms and their gut is off, that's where assimilation happens. That's where we're absorbing vitamins and minerals. So that could actually, so that alone may be an indication, but if they're on acid blockers, then you're stopping absorption of these vitamins and minerals. So it would be a very common thing. We see it all the time that people end up having these different deficiencies when they have the diagnosis of GERD. And also, I mean, there's other reasons why people have deficiencies. You can have, one of the things is that if the farmers don't use good topsoil, then you're going to end up with if the soil doesn't have the vitamins and minerals, then the food is not going to have the vitamins and minerals, and then you eat the food and you don't get the vitamins and minerals. And that's for somebody that's trying to eat healthy. If you look at it, over 70% of the American diet is the SAD, or the standard American diet, that's full of processed foods. So there's many reasons why they would have deficiencies, and if you look at all of these vitamins and minerals that are needed in gut health, good luck trying to figure all of this out from the top of your head. And then do you want to give them all of these supplements and all of these nutrients? It's just overwhelming. We have to try to get them the most bang for their buck. So how do we test vitamins and how do we test nutrients and see what they're missing? Well, the fat-soluble vitamins, you can usually check in blood because they're hanging around for a long time. They're fat-soluble, our body stores them, and that way that when we need them, we can use them. The water-soluble vitamins, however, and minerals, they end up they go in and out of your system pretty fast. So if you do standard testing for B6, let's say, and you didn't have B6 in that particular meal, it may say you're deficient. Or if you had a meal that contained B6, it may say you're fine, but when you look at it, chronically you haven't had enough B6 that can lead to neuropathy and energy problems and GERD and all of these other symptoms. So really just doing regular vitamin testing for most of these nutrients, even if you could go to one of the standard labs and order every single one of these vitamins and minerals that you're going to get in SpectraCell, you're not going to get a good feel for what they are really missing. You may for maybe vitamin D, you may if you do like an RBC magnesium, which is intracellular, but not for most of them. So if you don't use SpectraCell, well, I hope that you would consider it So what do we do with SpectraCell? Well, SpectraCell is looking at lymphocytes, and it's looking at lymphocyte needs and lymphocyte growth. So they take the blood and they check the different nutrients and see if they can stimulate growth with those nutrients. And if they stimulate growth, our lymphocytes last for about 3 to 6 months in our blood. That can give us kind of like an A1C for diabetes. That can give us a 3 to 6 month projection, or not projection, but really a feel of what vitamins they really, or nutrients their body is missing. Because if they're lymphocytes, you give a lymphocyte B6 and it says, oh my God, thank God, and it starts to grow properly, then first of all, then think of the immune dysfunction that person has because of B6. Could that lead to cancer? Could that lead to disease? But the other thing is, well, what about the other parts of the body that need B6? Maybe that needs some B6 as well. So it makes sense when we're trying to be comprehensive to do this. So what do? I'll do the SpectraCell analysis, the micronutrient testing. I'll sit down, I'll go over the results with them, replace what they need replaced, and then I always make a separate appointment for 4 to 6 months later. And my reason for the appointment is going to be SpectraCell draw, and then 2 to 3 weeks later, I usually do 3 weeks later, SpectraCell results. And I make that a separate visit. So what I'm trying to do is I'm trying to plan for the future. I'm going to make it a separate visit, because the last thing that I want to do is check their cholesterol and check their thyroid and check all of these other things. And by the way, here's your SpectraCell result. I want to sit down with them. I want to show them the report, and I want to go over it with them, because we're not only saying take these supplements. With SpectraCell, you're going to get a great handout if you haven't seen it before. And that handout is going to go over the different nutrients and what those nutrient deficiencies can cause and what foods have those nutrients in them. So it really should be something that deserves that visit, not to be just like a, by the way, your SpectraCell showed this. So my advice is make a big deal of it. And I mean, look at the 33 most important micronutrients that we have here. How on earth are we going to remember or just look at symptoms and figure out which nutrient deficiency they have? I think it's pretty obvious you really can't. We went over why we're looking at lymphocytes. And this is a sample report if you haven't seen one. So it shows which deficiencies they have, what borderline deficiencies they have, and then here it's showing you the growth and showing you like where the deficiencies at. Now here's the thing: you still may need to do some serum testing, because if you're toxic in a nutrient, it's not going to show. What it's going to show is lymphocyte growth. So realize patients may look at it and say, oh, does this mean I have too much vitamin E? Well, no. It means you have adequate vitamin E. What we'd have to do is we'd have to decrease your vitamin E and then recheck. Just a little tidbit. I know that's not what we're talking about, but if you're giving vitamin E, make sure that it's not the synthetic stuff, because the synthetic stuff may really mess them up. You need alpha, beta, delta, gamma tocopherol and alpha, beta, delta, gamma tocotrienol. So just make sure that they know the difference with vitamin E. And I just mentioned that because I mentioned it here. So anyway, moving on. So we are going to replace, and then we're going to re-inoculate. So we now know that for every 1 human cell, we have 10 bacterial cells on us. They're responsible for multiple things. They help us digest our food. They help fight against bacteria and other pathogens that may be trying to attack us. They actually can help with your mood. There's data on certain probiotics that the strains that can help people with depression and atypical depression and other things. So probiotics are very important. It can be as metabolically active as the cytochrome P450 in the liver. So it's very important that we have a good microbiome. And I'll tell you what, people with GERD usually don't. So you can give different strains of oral probiotics. You want to give prebiotics. And if they have SIBO, one of the things that I've been doing a lot lately is having them do probiotic enemas. So we also want to repair. So the body is damaged. We want to give it some of what it needs in order to repair itself. Remember, part of one of the diagnoses or what ways of diagnosing GERD is saying that it causes mucosal damage. If the acid causes mucosal damage, then that's GERD, that's pathogenic. So you need zinc in order to repair. Not only for your gut, if your zinc level is low, that can make your copper go up, and if your copper is up, copper can be one of those toxicities that can cause Alzheimer's disease. Vitamins A, vitamin C, vitamin E are needed for repair, omega-3 fatty acids, and the amino acid L-glutamine. And remember, so if you're on acid blockers, that actually may stop you from having these nutrients. And then rebalance. So remember, the psychological, spiritual, emotional state is tied into everything. So work with them on balancing their life and balancing their sleep and balancing their relationships, and work with them with heart rate variability or meditation, guided imagery, and that type of thing. And that's showing you in the functional medicine matrix where that plays a factor. So what are some other specific lifestyle measures you can do with people with GERD? Well, avoid supine positioning after eating. So don't just eat and then lay down. Try to avoid late night eating. Try to avoid alcohol and tobacco intake. So we're always going to be working with that. You can do things like healthy gum or lozenges, because that can promote salivation, because as long as you have that salivation flowing, that can help move things along. Now, what do I do after 1 month? So I'm going to see them. I will start them on melatonin or 5-HTP. I will work on some lifestyle things, and I'm going to work to 5 R's. I'm going to start them on that process. Check their vitamins, have them come back in, go over those results. And then once that treatment plan is initiated, then you always make that you always have that follow-up there. So when you see them for the follow-up, then if they're on a proton pump inhibitor at that time, then have them start decreasing that proton pump inhibitor to every other day. And then 3 weeks to a month later, we do it every 3rd day. And then afterwards, you have them stop it, and you keep doing your functional approach and reinforce the lifestyle changes. So they're actually, if you go to PubMed and if you search melatonin and proton pump inhibitor, what you'll find is that there's research that shows that people that use melatonin to get off proton pump inhibitors are much more successful if they don't. So there's research behind not only the theory behind it, but the protocol, and then frequent follow-ups. So I'll say, see you in a month to go over, see you in 3 weeks to go over vitamin testing or SpectraCell results. See you and follow up in 5 weeks and the reason for the visit is going to be wean PPI. And then they come in and you see that you realize you have to wean the PPI. So maintain those follow-ups. Don't give them a book of instructions to follow. No, there's that small. Now, if you have to, if they're out of town, you're never going to see them again. That's great. But I really like the small, frequent visit. It helps with the relationship, and it helps with the compliance. And be on the lookout for typical and atypical reflux symptoms. You got to tell them, look, you may develop a cough. You may start feeling like heartburn or chest pain, or these are all signs that everything's great, and then they go back to their old lifestyle, and then they start getting reflux again. You don't want them to just fight through it. You don't want to scare them about proton pump inhibitors to where then they end up having the complications. And then here are some considerations with our difficult cases. Check if the gastrin level is too high, check it. And if the gastrin level is, if they're not being able to come off the acid blockers, and if they have the severe symptoms, check gastrin. If gastrin's really high, they could have a very rare condition called Zollinger-Ellison syndrome, where they have a tumor that makes too much gastrin. But a lot of times it's just it's a kind of rebound from having the proton pump inhibitor. So then what you do at that point, then keep them on the proton pump inhibitor and have them do a betaine hydrochloride or hydrochloric acid with a protein-filled meal 3 times a day. And if they don't get heartburn from that, then that acid starts telling the body everything's okay, and the gastrin starts to release. Also, remember SIBO. So start looking for the other symptoms of SIBO. So if they have heartburn, but they also have bloating and all the other things that I mentioned that SIBO has, then work on their SIBO. You may need to do that removal. H. pylori eradication. You can do when they do an upper endoscopy, they check for this. But you can also do stool testing. And the stool testing, you can do serum testing, but it has its limitations. Stool testing may be a little bit better, especially for someone who has a history of H. pylori, to see if they have active H. pylori. But you can do stool for H. pylori. And then also probiotic enemas at some point may help, because if they have small intestinal bacterial overgrowth and you start giving them probiotics, certain strains of probiotic like bifidobacterium may get stuck in the small intestine and make the problem worse, where you want them in the large intestine, and that's why we go for the enema. Once they're off the PPI, like I mentioned, move upstream. So, okay, you don't need them on melatonin forever. Well, let's try giving them 5-HTP. Let's try to increase their tryptophan. So exercise, go out in the sun, make sure that you're getting enough sleep at night, and work on protein. Make sure they're getting enough protein. Maybe give them amino acids at first and then protein. Work upstream and try to get them off stuff, and try to use diet and lifestyle to help with their symptoms. So when the patient's off the medication, like I said, continue to try to get to the minimal dose needed. I just want to make all of us aware, just a nice reminder, that there are patients that may need an upper endoscopy. And the last thing you want to do is do a functional medicine or integrative medicine approach, and then you miss a cancer, or you end up with a severe ulcer that bleeds out. So there are certain alarm features that we just got to remind ourselves of, where you're going to really want to recommend that the patient goes and gets an endoscopy. And if they refuse, you want to make sure that you write in your chart that I strongly recommend an endoscopy, and patient understands that not getting an endoscopy could miss cancer and death and all those crazy things. And then just document and protect yourself, but also protect the patients, because we can't, yeah, you can take marshmallow extract, but and that may make them feel better, but you don't want to hide a cancer. So what are the indications for upper endoscopy? The alarm features like dysphagia, so difficulty swallowing, pain on swallowing, bleeding, if they have, black stool, or if they have hemoccult positive, if they have anemia, if they have weight loss, if they have recurrent vomiting. Vomiting, don't just try to do a functional approach. You just got to make sure. Severe erosive esophagitis on a previous endoscopy. If they went and they found out they had an ulceration, and you worked on this approach and they feel better, and they say, hey doctor, do I still have to do my endoscopy, my follow-up endoscopy? You say yes, because that ulceration could have been a cancer, and they just kind of missed it on path. So if an ulceration doesn't clear, then you want to make sure that you're following up, and if it doesn't clear, then it could be stomach cancer. And then make sure they continue doing their Barrett's esophagus screening if they have Barrett's esophagus. If they have GERD symptoms despite being a PPI and all the stuff you're doing, that's an indication as well. So what are our final thoughts? Due to our lifestyle, GERD is a major problem. Gut problems are usually associated with nutritional deficiencies. If you're checking serum to figure this out, stop, use your brain and order SpectraCell. And using a functional medicine approach what I found, can be extremely successful in not only GERD patients, but in all patients. Thank you guys very much for listening. I hope that this was beneficial. I hope that my sound worked and you guys aren't all there just wondering where the heck I went. And I would be more than happy to take any questions that you may have. Just whatever questions you have, go ahead and type them in the chat box.
Dr. Elyaman, your first question is on the chat box.
Yes, so as a functional medicine doctor, do you distinguish between GERD and eosinophilic esophagitis? The symptoms are often similar. Yes. So in order to diagnose the eosinophilic esophagitis, that's where the endoscopy comes in. If they have eosinophilic esophagitis, what you're going to work more on is those allergies. So what we would do is you can do skin prick allergy testing, or you can do the there's a test called immunocap testing, and you can do that. The major laboratory should have it. It's immunocap. It's much more accurate than RAS testing, and I'd find out what foods are bothering them and the environmental allergens that are bothering them. And sometimes there's cross reactivity. And then we're going to do, apart from avoidance, sometimes what we would do is sublingual immunotherapy. And sublingual immunotherapy, it's like the sub-Q immunotherapy, you know, or IM immunotherapy, where you're giving injections of those things that they're allergic to so that their body becomes desensitized to it and stops making antibodies towards it. But you do that as a sublingual that they put under their tongue, and that's something that we do in the office. And then what you're going to work on is, if you know they have eosinophilic esophagitis, that's a root cause, that's a problem with your immune regulation. And in particular, your problem is a Th1, Th2 imbalance. So what's happening is your Th2 is upregulated. So how do you downregulate your Th2? Well, certain probiotic like Bifidobacterium lactis, you're going to want to give them. You're going to want to give them, do the full functional medicine approach with all the environmental stuff. And then vitamin D helps downregulate that. So there's different things that we would do specifically for eosinophilic esophagitis, where if it's just reflux, we're going to go over the things I talked about in this lecture. So very good question. Number 2, does it make a difference in your experience if the melatonin is immediate or SR? So the melatonin is thought to have a direct effect. That being said, the one that I use most commonly is I do an immediate release. So I would be able to make a case for using just the direct, straight, fast-acting melatonin. But what I typically do is I give our melatonin extended release, which has 1 milligram of melatonin fast-acting and 4 extended release, and I have them try that at nighttime. So they have a nice slow-release melatonin throughout the 6 hours or 7 hours. Then, if that doesn't work, then I say, all right, well, let's try the faster-acting stuff. Or if they're groggy in the mornings, then I'll go for the fast-acting. But just from an intuitive point of view, it probably makes more sense doing the fast-acting. Okay, so 3, what recommendations do you have for someone with GERD and Barrett's esophagitis taking Protonix and Zantac for many years? Well, I think that is a person that definitely needs to do SpectraCell micronutrient testing, because you're probably going to have to give them the nutrients that they need and work on their gut and work on killing off bad bacteria, and you're going to have to work around it. Now, the problem with Barrett's and getting off an acid blocker, I would try to get them off the Zantac. So using this approach, I'm pretty sure you can get them off the Zantac and get them to the proton pump inhibitor dose that their gastroenterologist is okay with. Now, the problem with Barrett's, as you guys know, is it's precancerous, and you don't want someone to get esophageal cancer and then blame you for it. So there is a subset of people with Barrett's esophagus that don't actually have a problem with too much acid. It's actually a bile reflux. So bile is refluxing into the stomach, and that's basic, and it's not acidic, and that's what's causing it. So if you get with a gastroenterologist that is smart and progressive and willing to work with you, and they do a scope and they realize, shoot, the issue here is not an issue of, the issue here is not an acid issue, it's a bile issue, then that you can go on bile binders and they may let you come off the acid blocker. But do not do that unless you have good proof that a gastroenterologist is on your side, because at the end of the day, first cause no harm, and standard of care now is proton pump inhibitors. But that a very good question, and it's something that comes up all the time. All right, 4, melatonin linked to insulin resistance. Is it safe to give people with GERD? So too much melatonin may be linked. I'm not familiar with the insulin resistance. I am familiar with, in animal studies, it causing some hypogonadism in like birds. So the other thing to worry about, the main thing, so I'm not, like I said, I'm not sure about insulin resistance because I tend to see the opposite. I tend to see them needing melatonin when they're insulin resistant, and sleep actually helping people with their insulin sensitivity. But back to, so I don't worry about it with diabetes as much. But where you have to be a little bit careful is that if you give melatonin to people with asthma, it, especially an exacerbation of asthma, it can worsen an exacerbation of asthma. So maybe if we do another one of these, we can talk about the functional medicine approach to asthma. But that's something to keep in consideration, and that's why you're going to use. I'd rather have melatonin than a PPI, but then I'm going to want to get them off the melatonin. I don't want to just put them on a supplement for the rest of their life. I want them to do the lifestyle thing so they don't need it anymore. Now, next question: a patient has high B12, has been classified as anemic, and has chronic diarrhea. What can cause the patient's high B12? Well, there are different SNPs. There's genetics. You can have a issue with methionine synthase reductase where you can't where you have the B12 but your body can't recycle it. And also a lot of times though patients are on supplements that have B12 in them, and that's what's causing it. But it could definitely be a SNP issue where the B12 is kind of stuck in the raw form. All right, so then anything special for esophageal dysmotility? These patients have GERD too. So there is a product called Iberogast. It comes from Europe, and it's used. It has I believe 7 different herbs in it, and it helps with or it's indicated for irritable bowel disease, but I've seen it help with esophageal motility. Another thing to work with that helps with esophageal dysmotility is intermittent fasting. So if they can do some intermittent fasting, that can help as well. And I think that's it. That's all the questions I got. Oh, last question. For a patient with a hiatal hernia not needing or being a candidate for surgery, what do you recommend? I recommend all the same things that I just discussed. A lot of times people will have a large hiatal hernia and it doesn't cause a problem, or it doesn't cause a clinical significant problem. On the other hand, there are people with no hiatal hernia and they have severe reflux. So I treat them the same, and many times people with a hiatal hernia and GERD, their symptoms go completely away using a good functional medicine approach. Thank you guys very much for listening. I hope this helps.